everyone, and welcome to the third session, which I'm taking up for pediatric postgraduate learning. And today I'm going to go with an interesting topic, that is malaria. All right, so coming first to introduction to malarial infection. Uh, it's Why do we need to study it? Because it is a major public health concern. All right, it's a major public health concern, and in India one needs to know about malaria, especially in children. Okay, and this problem has been enhanced by drug resistance. Okay, you need to know that drug resistance is rampant in malaria. Okay, and this has uh, a very uh, important etiology to the spread of malaria. Because of resistance, it just keeps on spreading. So let us know some factors which are causing this drug resistance. One of them is haphazard use of drugs. Okay, another one is population movement. Population is moving, so endemic regions, it's going from endemic regions to its outside its endemic regions, so it's spreading. Okay, and then there is infrastructure deficiency in our country. All right, and there is unplanned development, urban development, so therefore it may cause. And one of the another factors is deforestation. All right, so this can spread the mosquitoes into the urban population, and therefore deforestation can also lead to spread of the. But the most important factor which is important for drug resistance is something called as drug pressure. Okay, so it's basically nothing but how a drug, basically, the drug pressure is nothing but, because of the use of drugs, the genetics of the microorganism changes, and they kind of become resistant. Like, it's like basically selection of the population which is resistant to the drugs. Because see, you're killing everyone who's with whatever is susceptible, you're killing it, but what is not susceptible is getting left. Okay, so what is resistant is getting left, and you're doing this for years and years, so therefore now we have only the resistant strains. So this is nothing but what is the effect of drug pressure. Now I'll talk a little bit about the etiology, which is nothing but the organism. The organism is what is a protozoan. Okay, it's a protozoa, right? It's a protozoal infection, and genus is Plasmodium. All right, genus is Plasmodium, and it is spread by the bite of female Anopheles mosquito. Okay, bite of female Anopheles mosquito will spread the disease. What are the species which you know of? Now, very commonly which you know species are falciparum. Okay, and there is vivax. All right, and there is ovale, and there is malaria. Okay, so the most common ones are which? Falciparum and vivax, most common. All right, now there is a fifth new species found which has a zoonotic transmission in the zoonotic transmission, that is in monkeys. Okay, and it is recently found, and it is known as Knowlesi. All right, so this is the uh, major part of the etiology. Now coming to the life cycle. this is something which is basic, which you have been learning from 11th and 12th, and the life cycle of malaria. So firstly, I'll talk about how the infection starts in the human. First, okay, first there's a mosquito which takes a blood meal, all right, and injects sporozoites. All right, it injects sporozoites. This sporozoites within 30 minutes to 1 hour will reach the liver cells, that is hepatocytes. All right, in the liver cell, the human liver stages will go on. That is, it's an exoerythrocytic cycle. So let me change the color for that. Exoerythrocytic cycle. Okay, exoerythrocytic cycle. This is the exoerythrocycle cycle. So liver cell is getting infected liver cell. All right, and this will convert into schizont, and this schizont will ruptured schizont, which will release what? Merozoites. All right, it will release merozoites. Now this merozoites may enter a liver cycle again, or may enter the RBCs. So when they enter the RBCs, it is called as erythrocytic cycle, and it starts with nothing but immature trophozoite, which is the ring stage. All right, this ring stage, immature trophozoite becomes mature trophozoite, and from mature trophozoite you get again another schizont, and this schizont will also again rupture schizont, again release merozoites, which will again enter another RBCs. So this is entering RBC here. So what is this cycle called? What is this cycle called? This is called as erythrocytic cycle. Erythrocytic cycle. So we have understood the exoerythrocytic cycle and the erythrocytic cycle. Now what happens, how do we, this is all in the human, right? So how does it go to the mosquito, and what happens in the mosquito? Let's understand. Now sometimes what happens is the immature trophozoites, that is the ring stage, sometimes few of them, not all, go to form mature trophozoite. Some develop into immature gametocyte, all right, which again become mature gametocyte. All right, and this mature gametocytes, that is, what are the mature gametocytes? Basically, the mature gametocytes are nothing but microgametocyte and macrogametocyte. So these ones again are taken by blood meal, in which the mosquito will ingest the gametocytes. All right, and after that what happens? This ingested gametocyte will convert into two. There is one called as macrogametocyte, okay, and there's another one called as microgametocyte, and this microgametocyte is flagellated. So it starts X-flagellation. Okay, it starts X-flagellation. So basically one forms 8. This is something which you remember from the, so one microgametocyte will have 8 of them, one main microgametocyte, and then after this the fertilization takes place. That is, in fertilization what happens here, we're not exactly calling it fertilization, but what happens here is, here a microgamete will enter into a macrogamete. Okay, microgamete enters macrogamete. Alright, and this develops into ookinete. The ookinete develops into oocyst. This oocyst will rupture and release sporozoites, which go into the salivary gland of the mosquito and rest there, and they'll again enter through the bread meal into the humans. So this is roughly the life cycle, which is not required at this level. Like this is something which is basic. I don't want to go into the details. So what you need to know is, in the mosquito, the cycle is called as sporogonic cycle. Okay, sporogonic cycle. So what you need to know is about the three parts of the entire entire malarial cycle is: one is exoerythrocytic cycle, erythrocytic cycle, and sporogonic cycle. So these three you need to remember. All right. Now let's move ahead to important stuff which pediatricians should know, which starts with, I'll use this color. It starts with pathophysiology. Pathophysiology of the disease. Okay. Now I'll be talking this in a little depth, and this might get a bit boring, but hang on, it'll get better. All right. So first you need to know the pathological changes which occur in malaria is caused by the destruction of the RBCs. Okay, there is destruction of the RBCs, and there is production of cytokines, and there is stimulation of intravascular synthesis of nitric oxide, and then there is further sequestration of infected erythrocytes. So what all happens, pathological changes in malaria, you need to know, are due to: number one, destruction of RBCs. Okay, number two, production of cytokines. Number three, stimulation of intravascular synthesis of stimulation of intravascular synthesis of nitric oxide. And number four, sequestration of infected erythrocytes. All right, so this is all what is happening. Now what happens if there is now I'll just explain a little bit about each. So what happens if there is lysis of RBCs? Okay, when there is lysis of RBCs, what exactly happens? Lysis of RBCs causes anemia. This anemia may be acute, or this anemia may be severe. Very sorry. This anemia may be acute, or this anemia may be chronic. This anemia may be acute and severe, or this anemia may be chronic. Okay, in chronic, it can become chronic also sometimes. So this chronic causes of the chronic are basically hemolysis. Number one, continuous hemolysis going on for days and days. Okay, so it's not exactly acute. It's not an acute and severe one. So this will be having to do hemolysis. This may be due to inadequate erythropoiesis. Okay, long-standing infection this is, and this may be due to bone marrow depression. This is basically a long-standing infection of malaria, not an acute infection. And it may be even due to folic acid deficiency. Secondary folic acid deficiency may be there. Okay, and if there is acute and severe malaria, which is the most common presentation, it will have hemodynamic consequences. Hemodynamic consequences. Okay, This you need to know. The intravascular hemolysis may sometimes be severe. Okay, the intravascular hemolysis may sometimes be severe, and this what happens when there is intravascular hemolysis? Even hemoglobin comes out, so you get hemoglobinuria. This hemoglobinuria, if pronounced, can produce something called as black water fever. Okay, pronounced hemoglobinuria may cause black water fever. Okay, now this intravascular hemolysis may be a precipitating event in the development of some other manifestations like renal failure. Okay, this renal failure is also a complication associated with quinine treatment. Okay, now hematopoiesis overall is suppressed during acute infection and it is not reversed easily, and that will lead to the chronic anemia. Now coming to I told you about the cytokines. In cytokines, what you need to know is TNF and IL-1 are the most important cytokines which are responsible for the pathogenesis. It has been found that there is higher concentration of tumor necrosis factor in cases of cerebral malaria and in cases of severe malaria cases and in cases which are having prolonged hospitalization compared to the ones which did not have that. So definitely TNF is a cytokine which is important for pathogenesis and is an indicator of severity. All right. Now we talked about the sequestration of the infected RBCs. We discussed about that. Now sequestration of infected RBCs is thought to contribute to the clinical manifestations of malaria. All right. And late stage parasites will induce host cells to develop. These late stage parasites are there, right? Late stage parasites, they'll induce the host cells, that is host RBCs, okay, to develop knobs on the surface. Okay, this is the RBC, it will develop knobs on the surface. These knobs on the surface will facilitate adherence to the vascular endothelium. So because of the development of, so these late stage parasites are inducing the host cells, that is the RBCs, to develop knobs on their surface, and this will facilitate the adherence to the vascular endothelium, and this may cause the manifestations of malaria and more complications. Now effect of the sequestered RBCs results impaired perfusion, impaired nutrition, and impaired oxygenation of the surrounding tissues. So all these are gone. Perfusion is not well, nutrition is not well, and oxygenation is not well. And these are the main causes of the complications in falciparum malaria infection, that is cerebral malaria, renal failure, or diarrheal manifestations. Okay. Along with this, there is consumption of glucose in high amounts by the metabolically active late stage parasite. Okay. Late stage parasite will use up the consume the glucose, and this will cause what? One is hypoglycemia, definitely, and when glucose is not there, what happens to the aerobic metabolism? Lactic acidosis. Okay, so these two things will happen with late stage parasites. Now coming to clinical features. This is important, and this is not something which we can just discuss within 2-3 minutes, just clinical features, blah blah blah. No, we need to little understand a bit, because this is postgraduate level teaching. The factors on which the clinical features will depend. There are some certain factors on which the clinical features will depend. Number 1, species. Which species is causing the infection? Okay, that will definitely affect the clinical features. Number 2, immune status of individual. Number 3, what was the mode of transmission? And whether already the individual was on prophylaxis or not. Okay. Now, infection is usually an initial infection or a recurrent infection. Okay. Infection can be an initial infection or a recurrent infection. Now, recurrent infections are due to three things. There is something called relapse, there is something called recrudescence, and there is something called reinfection. Okay, we will discuss each of these now. Now, what is relapse? Okay, what is relapse? Relapse is result of delayed maturation of what? Of dormant liver stages, of dormant stages which are hypnozoites, dormant stages which are usually in the liver, that are hypnozoites. So hypnozoites will cause the relapse. And which species have hypnozoites? Hypnozoites are in vivax and hypnozoites are in ovale. Okay, so these two species can cause relapse. Now there is something called recrudescence. What is recrudescence meaning? It's the parasitemia which is caused by same parasite which was responsible for the initial infection, which was responsible for initial infection. Then what does it mean? Like, what is the meaning? Like, how can we call it as a, recurrent infection? Like, what is the meaning? Like, why are we calling this a recurrent infection? This will recur. This is basically after initial infection, but this is recurring after clearance or significant reduction in initial parasitemia. Okay, and this is due to drug resistance. This is mostly due to drug resistance. So initially the response will be good and the initial parasitemia will fall, but the same organism will again spread and cause the same infection. So this is drug resistance, and this is present in P. falciparum. Okay, and less commonly it can even be due to P. malariae. Now what is reinfection? Reinfection is an infection with a different parasite or infection with more than one type of plasmodium. Okay, so this happens when there is a high intensity of transmission, means highly endemic area, highly endemic area. So that is reinfection. So there has to be in a different species. Okay, more than one type of plasmodium, is infecting here. Okay, now coming to classical features of malaria. Now clinical features per se we'll talk. Now what is the result of like we discussed, what is causing the malaria? What is causing the malarial features is the result of the malarial result from something called as malarial paroxysm. This malarial paroxysm is due to lysis of parasitized RBCs and release of merozoites into circulation. When does this happen? At completion of asexual reproduction, that is in the humans. Okay, asexual reproduction. There is a malarial paroxysm where the lysis of the parasitous RBC is release of merozoites into circulation. Okay, hemozoin granules, if you remember from your 11th and 12th, and even from the I think microbiology. So these cause the paroxysms. So what are the features? You have fever, you have chills. Okay, you have fever, you have chills, you have headache, you have body ache. Okay, you have headache, you have body ache, you have fatigue. Okay, you have dizziness, you have malaise. Okay, there might be some GI symptoms like nausea, vomiting, abdominal pain, diarrhea. Okay, some respiratory symptoms like cough and dyspnea. Okay, sometimes all this may. The physical signs which you need to know, which are important, are pallor because of anemia, jaundice because of the hemolysis, okay, and hepatosplenomegaly. These may be present, which are classical signs which are found in malaria. Now, lab findings, the most common lab finding in clinical features is anemia in lab findings. Thrombocytopenia may also be present, okay, and it could sometimes be, thrombocytopenia can sometimes be a first manifestation of an uncomplicated malaria. LFT sometimes may also be abnormal, okay. Now, like we discussed, hypoglycemia, again it comes, means how clinically the patient may present. There may be pallor, and there may some bleeding manifestations. Okay, hypoglycemia may be present, and we told hypoglycemia ka cause it's due to the consumption of the glucose, and very much commonly occurs with falciparum malaria, but sometimes may occur due to enough treatment also. Sometimes what happens is quinine can cause hypoglycemia. Okay, so with the malaria, especially falciparum malaria, you can get hypoglycemia and quinine, and this, if there is hypoglycemia, there will be poor prognosis. Okay, there may be sometimes hyponatremia in your ABG. You can feel hyponatremia and acidosis. Okay, and this hyponatremia, if present, is mostly associated with SIADH. Sometimes there may be acute renal failure. In an acute renal failure, obviously RFTs will be deranged. Okay, now what is found very interesting is, then why do some people develop uncomplicated malaria, why do some develop complicated malaria, like what is it about? So this is severe and complicated malaria. Like I told you in the initially in the discussion of clinical features, there are certain factors on which the clinical features are depending. The severe and complicated malaria develops in non-immune individuals who are most susceptible. Okay, and what are the complications? Common complications are cerebral malaria, pulmonary failure, ARDS, renal failure, severe anemia, hypoglycemia, and metabolic acidosis. Now coming to very important discussion is, there are two things to know in malaria when you come in clinical features. There is something called as severe malaria. Don't get confused. There is something called as severe malaria, and there is something called as complicated malaria. Now, who defined this? Who told what is complicated, what is severe? Is there any proper authority which is telling? Yes, severe malaria has been described by CDC, that is Center of Disease Control. Complicated malaria is told by WHO criteria. Okay, and both are similar more or less, but still you have to know each of them. CDC criteria for severe malaria: cerebral malaria, number 1. Severe anemia. Please concentrate in this. This is a postgraduate point. Okay, you need to know what are the characteristics of severe malaria. What is counts as severe malaria? Cerebral malaria, severe anemia, acute renal failure. All right, hemoglobinuria, hypoglycemia, metabolic acidosis, hypotension due to cardiovascular collapse, ARDS, coagulopathy, and hyperparasitemia. What is meaning by hyperparasitemia? Means more than 5% RBCs are infected. Okay, so these are all the features of severe malaria: cerebral malaria, severe anemia, acute renal failure, hemoglobinuria, hypoglycemia, metabolic acidosis, hypotension, ARDS, coagulopathy, and hyperparasitemia. Now, complicated malaria lies on like similar lines. Basically, it doesn't say all these names like malaria and cerebral malaria and all that. It describes prostration, impaired consciousness, coma, or convulsions as one category. All right. Another one is severe anemia, renal impairment, hemoglobinuria. All right. Hypoglycemia, that is less than 40 milligram per deciliter. All right. Acidosis or hyperlactatemia, acidosis or hyperlactatemia, circulatory collapse or shock. Okay, circulatory collapse or shock, respiratory distress or pulmonary edema, abnormal bleeding, jaundice, failure to feed. Okay, and then very interestingly, hyperparasitemia is described in two ways here. So you divide it into low transmission area or a high transmission area. In high transmission area, only if more than 5% infected RBCs, but in low transmission area, even more than 2% is counted as a criteria for complicated malaria under WHO. Okay, let me discuss a little bit about each. Okay, little bit about each, because these are important points which you need to know as a postgraduate. Severe anemia is most commonly found in less than 1 year age group. Remember this. And where does it occur? In which areas? Areas which are endemic. So areas with year-round transmission. Year-round transmission. All right. And it's incomplicated, less than 5 gram per deciliter HB is present, hemoglobin, and sometimes the anemia can occur because of complication of treatment. What treatment? Artemisinin combined therapy. Okay, artemisinin therapy, and sometimes, sorry. Sometimes it occurs because of hemolysis. All right, hemolysis of RBCs. Okay, sorry very much. So artemisinin therapy is there, and there is hemolysis of RBCs, which you know as the cause of the anemia. And next is hypoglycemia, which I would like to discuss. Hypoglycemia. All right. In hypoglycemia, we have already told less than 40 mg per deciliter, and we have told causes. That is, number 1, parasitic consumption of the glucose. Number 2, quinine treatment can cause. And why quinine treatment causes hypoglycemia, you need to know, is there is insulin secretion due to quinine, so there may be hypoglycemia because of that. And number 3, there may be inadequate gluconeogenesis in the liver because the liver is affected. So there are 3 causes, and this may be present in up to 20% of children with severe malaria at admission. 20%. Okay, and what is the treatment? Immediately IV bolus should be given. What bolus? 25D. 25D, 2 to 4 ml per kg should be given, and this should be followed by a slow infusion of any fluid which contains 5D. You should have the 5D in the fluid so that the hypoglycemia does not reoccur. Alright. Coming to acid base changes. Acid base changes. In acid base changes, there is metabolic acidosis, as you know. Metabolic acidosis can occur in severe malaria, and this is a marker of malarial illness severity. Okay, and this clinically manifestations as hyperthermia. Okay, there is increased respiratory rate. Acidosis is associated with hypoglycemia as well, and the treatment is basically fluid resuscitation. Treatment of acid fluid resuscitation you should do, and along with that you should start anti-malarial therapy. Okay, anti-malarial therapy should be started. Now coming to renal complications. Renal complications, typically you get a renal failure, that is acute renal failure, which is typically oliguric. Okay, and it is oliguric, and in oliguric phase it is reversible, and if dialysis is supported, otherwise it will go into the irreversible phases. Histological changes in renal complications is acute tubular necrosis, which occurs in the black water fever, and there might be sometimes, very rarely, nephrotic syndrome occurring due to malaria, especially in P. malariae. And P. malariae is also known to cause chronic failure, chronic renal failure. Okay, so this P. malariae is very bad person. So this will cause nephrotic syndrome also and chronic renal failure. P. malariae, that is asymptomatic proteinuria, hypertension, sometimes hematuria may also manifest in these cases. Coming to respiratory complications. Respiratory complications. Pulmonary edema is found late in the course of severe malaria due to capillary leak. Okay, pulmonary edema occurs. And ARDS, that is pulmonary inflammatory response, this is driven by the alveolar macrophages. So this will cause ARDS. Okay. Now coming to an important complication which is very common and dangerous and life threatening. I have seen many cases die, okay, with cerebral malaria. So it's the most common complication of falciparum malaria. Okay, most commonly occurs in the age group 3 to 6 years. It presents with altered level of consciousness. Okay, and there is diffuse encephalopathy and prolonged multiple seizures. Okay, diffuse encephalopathy and prolonged seizures. Status, okay, prolonged seizures, multiple. Sometimes the child may present directly in comatose stage with no response to stimuli and opistotonic posturing. Okay. Okay, raised ICT signs may also be found sometimes. Okay, now what are the factors which have been found to be associated with neurological sequelae? One is severe anemia. If there is severe anemia, likely to go into cerebral malaria. If there is prolonged coma in the child, likely to end up with neurological sequelae and multiple seizures. So these are the factors which will associate with poor long-term neurological sequelae. Okay, what are the sequelae which we are talking about? Hemiplegia. Okay, the child may end up with hemiplegia. The child may end up with cortical blindness. The child may end up with aphasia. The child may end up with ataxia. Okay, this is about cerebral malaria. Okay, which you need to know, important points. Now coming to very interesting and actually a very important point, because these people always keep asking this to the postgraduates. I have also been asked a lot of times in my PG when I did my PG recently. Malarial retinopathy. What are the retinal findings of malarial infection? Okay. Now, why the all the consultants are like eagerly asking the postgraduates this question? Because retinal changes are a prognostic indicator. Okay, so you are able to say the prognosis based on the level of retinopathy which is present in malaria. Now, basically, what all happens is there is vessel discoloration. There is vessel discoloration. Usually, this appears as orange. Okay, and you have retinal hemorrhages, papilledema sometimes. Okay, and there is a very peripheral retinal whitening is an important feature. Okay, for you I have, so that you know, so that it's etched in your head, I have gotten the pictures for you. Now this is, now can you see the arrowheads? This arrowheads is showing macular whitening, that is macular edema. Whenever there is macular edema, it becomes whitened. Okay, so this is macular whitening, all right, which is the macula. And what is happening here? This is the vessel discoloration which is happening. See, normal vessel is red, but here you see the vessel is discolored. So this is the vessel discoloration which you can see in malarial retinopathy. And see this one, this is peripheral retina. Okay, this is peripheral retina, and this peripheral retina is showing whitening. See, can you see? Entire picture is white. So whitening of the peripheral retina. Okay, so these are important manifestations of malarial retinopathy. Okay, which you need to know, and it's very favorably asked by the consultants. What are the findings of malarial retinopathy? Now, a little bit a note on something called as tropical splenomegaly syndrome. What are the other names? If someone asks, hyperreactive malarial syndrome or hyperreactive malarial splenomegaly. What happens in this? There is massive splenomegaly. Massive splenomegaly. In this, there is high concentration of total serum IgM and malarial antibodies in the individual. Okay, it's basically a clinical and immunological response to anti-malarial agents. Okay, the pathogenesis being a chronic exposure to malaria resulting in chronic stimulation of the immune system, and this is on the fertile soil of a genetic factor. So there is genetic susceptibility, and this all will result. Okay, hyperimmune response. So what are the clinical findings? There's a huge spleen which is more than 10 centimeters below the costal margin, enlarged liver. Lab findings will be anemia, increased retic count, elevated IgM. IgM will be more than 2 standard deviations. Alright, high antibody levels of anti-malarial antibodies. Alright, this is basically a pre-malignant condition. That's why you need to know this can be a pre-malignant condition. What is the treatment? Treatment is lifelong treatment with anti-malarials. Okay, in home, in endemic areas. If they are outside the endemic areas, then 7 days treatment with anti-malarial should be done with close monitoring of the spleen size outside the endemic areas. Okay, na? Now coming to the another point, congenital malaria. What is congenital malaria? Congenital malaria most commonly occurs because of PY-vax. Okay, and never it has been reported with nolicity, and it occurs in 0.1% of immune mothers and 10% of non-immune mothers. Okay, the onset of symptoms are insidious at 2 to 8 weeks of age in the baby. The typical malarial paroxysm is absent in this, and this presents with basic manifestations like poor feeding, fever, vomiting, diarrhea, irritability in the child. But the important clinical finding is hepatosplenomegaly. Okay, lab findings are there in which there may be anemia, but thrombocytopenia also may sometimes be present, and jaundice. Okay, that is raised TSP may also be present. So this was all about the clinical forms of malaria and clinical manifestations, complications, when to call severe malaria and all that. Now going to the diagnosis,